Thank you. Thanks very much, Monique, for the introduction. And you read the title, so I'm going to skip through to the first slide. So first of all, before I start, I would like to acknowledge a few people, in particular, John Ojic, who works for the Occupational Health Clinics for Ontario Workers. John has really been tireless in terms of his work trying to understand the experiences of workers in Canada. He's done a lot of great work getting together surveys on the psychosocial work environment and these surveys, which are around the experiences of workers during the pandemic. So, this work really couldn't have been completed without John. So he has done so much, he even gets his picture up here on the slide. The Occupational Health Clinics for Ontario Workers have also been pivotal in terms of getting this work done, in terms of supporting the survey and the collection of the data. Also, I'd like to acknowledge members of the ad hoc pandemic survey group, in particular Dorothy Whitmore, Laura Lazansky and Alec Farquhar for their input into the surveys and their help in terms of disseminating the surveys, and Guy Potter and Cam Mustard, who are co-authors on the two papers that I'll be presenting today. So I've almost got a presentation within a presentation today. For those of you who have trouble or get a bit of Zoom fatigue, I'm going to summarise the results in 5 minutes, and then I'm going to go on to describe them in a bit more detail. But before you get the results, you're going to have to answer 2 questions for me. So I'd like to start with a quick overview of today's presentation. We did 2 pan-Canadian worker surveys between April and June 2020. Survey 1 was the survey of healthcare workers, which the total number of respondents was just under 6,000 healthcare workers. Survey 2 was of non-healthcare workers with just under 4,000 respondents. In the first survey, everyone was still at the work environment. In the second survey of non-healthcare workers, 42% of the workers were working remotely, 51 were site-based workers, and 7 had lost their jobs. In both surveys, we included 2 screening instruments. One was a screener for anxiety, and one was a screener for depression. And we also had a series of questions which were assessing various PPE, personal protective equipment needs, and also infection control procedure needs, and assessing how well these needs were being addressed. So here are my questions for you. I'm going to run a poll here to start with around in terms of the symptoms of anxiety. So the screening instrument we use for anxiety has scores of 0 to 6. And there have been studies that have shown a score of 3 or higher has a sensitivity of 0.86 and a specificity of 0.83, so a likelihood ratio of about 5, compared to a physician-diagnosed general anxiety disorder. So these are screening instruments. Scores of 3 really indicate that there's a high likelihood that a person has anxiety disorder and would require a further assessment. So the first question, which I'd like people online to answer, and I'm going to set the poll up in a second, is just to give me a sense of how many workers in our sample and our 2 samples put together do you think would have met the criteria for anxiety symptoms? So these are scores of 3 and higher. So I'm going to launch the poll now. Hopefully you can see, and you can just, if you're on a touch phone, you can click on your screen. You can, I guess you can use your mouse if you're on a computer. So the options are 10%, 20%, 30%, 40%, or 60%. And I'll close off the poll in about 5 seconds. Okay, and I'm going to share the results. So in terms of the results, so I guess 44% of people think that about 60% of our sample would have had anxiety disorder. 32% of you expect that about 40% of the sample will have anxiety disorder. So obviously people think that there's going to be a lot of people in the sample that have anxiety disorder. Behind that poll. Okay, so I'm going to go to another question. So I guess we're thinking at around about 50% of the sample will have symptoms of anxiety. So one of the things we wanted to do was compare groups. So you could think about this in terms of groups which have safe work protocols versus groups that don't have safe work protocols. And the second question is, if you thought about the absolute difference in that group, so just say here, group A was 50% of the sample, or group B, sorry, is 50% of the sample, how much higher would group A need to be in terms of an absolute percentage point? So if, would it be, if group B was 50%, would group A be 55%? Would that be an important difference? If group B was 50%, would group A need to be 60%? So a 10% difference before you thought it was an important difference. So here is the next question, which is, what is the smallest difference between two groups of workers in terms of their symptoms of anxiety that you think is important? So this would be, as I said, sort of a 5% difference between groups, a 10%. We're talking about absolute differences here between groups of workers. Okay, I'll close off the survey in about 5 seconds again. Okay, and so in terms of these survey results, so I guess almost half people say about a 10% difference. So if one group had 50% that had symptoms of anxiety, and if the other group had 60% or I guess 40% of symptoms of anxiety, that would be an important difference. 31% say it's about 20% difference. There's a few people who have said sort of 30% or 40% in terms of an absolute difference, which is quite high with differences of about 90% there. So I'm going to hide that now. And I'm going to give you our results now in terms of 5 results that you could take home today. So in terms of symptoms of anxiety, 55% of our healthcare sample and 42% of the non-healthcare sample met the criteria, the screening criteria for symptoms of anxiety. And it was 42% and 35% in terms of the symptoms for depression. We observed absolute differences of 18%. So in terms of the prevalence of anxiety between healthcare workers, which had none of their PPE needs met compared to those that had 100%. So among workers who had 100% of their PPE needs met, 43% of those workers had symptoms of anxiety compared to 61%, which had none of their PPE needs met. So that's a difference of 18%, an absolute difference of 18% in symptoms of anxiety. We observed absolute differences of 22% among workers in the prevalence of anxiety among non-healthcare workers who had none of their infection control procedure needs met compared to those that had 100% of their infection control procedure needs met. So that's 30% of workers that had all their infection control procedures met had symptoms of anxiety compared to 52% of workers that had none of the infection control procedure needs met. So a difference of 22%. Among site-based workers who are not working in healthcare, which had 0% of their infection control procedures met, these workers had higher symptoms of anxiety than respondents who had lost their jobs. So working without adequate protections in terms of infection control procedures led to higher rates of anxiety than losing your job in terms of the current pandemic. Site-based workers among the non-healthcare sample, which had 100% of their infection control procedures needs met, had actually slightly lower symptoms of anxiety than those who were working remotely. So again, for those workers who are still based at site, but who perceive that they've got all their infection control procedures needs met, they had the lowest levels of anxiety in terms of the non-healthcare workers, in terms of the survey that we did on non-healthcare workers. So that's the results in a nutshell, 5 of them that you could take with you today. If you want to hear more about how we've managed to come up with these results, then I'm now going to get into the presentation and give you a bit more detail on our studies. So in terms of the study samples, I've described these briefly before. I'll give you a little bit more detail now. For the healthcare worker sample, we collected survey responses between April 7th and May 13th, 2020. There was just over 7,000 respondents who started the survey, of which just under 6,000 answered the questions we needed in terms of understanding the relationship between PPE, infection control, and symptoms of anxiety and depression. For the non-healthcare worker sample, That started a little bit later, April 27th, went through to June 6th. 5,000, just over 5,000 respondents started the survey, of which we focused for this sample on the respondents who were employed on March 2nd, 2020. And we got answers to that question from 3,000, just under 3,800 respondents. This sample is a bit skewed towards education and government services compared to other industries in the Canadian labour market, although we still did get good responses from the retail and food service, which was 7% of the sample, and manufacturing, which was 5% of the sample. All responses were collected using a web-based survey, which was designed from OCAL and distributed through various labour organisations across Canada. We used a convenience-based sample, which means that the link was sent out to anyone who is on the email list for these organisations. So we can't really estimate response rates, but we did compare each of the populations, or each of the respondent populations, to the target population, which would be people who are working compared to the Canadian Labour Force Survey. In terms of the healthcare sample, slightly more respondents with 35 to 44 years of age, a few higher proportion of female respondents, more with longer job tenure and fewer part-time workers. We actually had quite a low participation rate in Quebec in terms of the healthcare sample. However, it's important to point out just the size of the sample is quite large. It's about 7.6% of the entire healthcare workforce at the time that we conducted the survey. And if you compare that to, say, for example, something like the Labour Force Survey, which surveys a bit less than 1% of the population, we do have a pretty good snapshot here of the healthcare workforce at this particular time, albeit not in Quebec. In terms of the non-healthcare sample, we do have more respondents from the education industry. Respondents are slightly older than non-healthcare workers in the labour force, more female respondents than male respondents, and slightly longer job tenure than what we get in the Canadian labour market. But again, in general, quite a large sample of non-healthcare workers did give us responses, so we could assess how well infection control and PPE needs were being met and its relationship to mental health in these two samples. In terms of the respondents, so here in this graph just shows the number of respondents per day. Healthcare workers are the blue bars, non-healthcare workers are the red bars. You can see these are both, you need to look at the left-hand axis to put those numbers in context. So we went from a high of almost 700 to 800 responses in a day, down to around less than 100. On the right-hand axis is the cases of COVID cases in Canada at that time. And so if you think about the first wave of the pandemic, where cases peaked at just over 2,500 cases, these surveys were conducted right in the middle of that first wave. And so they sort of, as the COVID cases drifted off in terms of the first wave of the survey, this is when the surveys were closed around the 6th of June, 2020. In terms of the outcome measures, so I described these briefly before, we used the Generalised Anxiety Disorder Screener, which is called the GAD-2, and the Patient Health Questionnaire Screener, which is the PHQ-2. These both offer, I guess, the advantages of brevity in terms of a large survey. They both consist of 2 questions, which are, over the past 7 days, how often have you been bothered by the following problems? So the anxiety screener asks about feeling nervous or anxious or on edge, or not being able to stop or control your worrying. The depression screener talks about having little interest or pleasure in doing things, or feeling down, depressed or hopeless. The response options to each of these are not at all, several days, more than half the days, and nearly every day. And you can take the 2 questions, which are scored from 0 to 3, you can add them together, which give you a score from 0 to 6. As I said at the start, a score of 3 or higher. So when people report having these symptoms, either one of them for several days and the other for more than half the days, or both of them for more than half the days, these people meet the screening criteria for anxiety and depressive disorders. In terms of the independent variable, the main independent variable we looked at, we focused on the perceived adequacy of personal protective equipment and infection control procedures. So we grouped people into 4 different groups, groups that had 100% of their needs met, groups that had 50 to 99% of their needs met, groups that had 1% to 49% of their needs met, a group that have 0% of their needs met. And I'm going to describe in the next slides just exactly what we asked about and how we to find needs being met. In the non-healthcare sample, we also had additional measures where we could look at people who are working remotely and those people who had lost their employment. And so for those, we extended this to 6 groups working remotely, the different policy and procedure needs or infection control procedure needs groups, and then those people who had lost their employment. In terms of the adequacy of personal protective equipment, so we asked about 10 different types of personal protective equipment. There's a little asterisk here, there were some which we only asked in the non-healthcare worker sample, which was around soap and running water and regular cartridge respirators. For each of the different types of PPE, we asked people to tell us about the responses using these 7 different response types. So if it was appropriate and with adequate supply, the appropriate type but inadequate supply, inappropriate type but adequate supply, the inappropriate type but with inadequate supply, it was needed but not available, and then people who said they weren't sure if it was needed or not, or if they didn't think it was needed, it was not applicable. When people responded in one of the first 5 categories, we said that type of PPE was needed for those workers. And when they told us it was the appropriate type with adequate supply, we said that need was met. So the row bar here is where it was needed, and then those people who said they needed that type of PPE, but it was either inadequately supplied or the inadequate type or not available at all. In those cases, we said that need was not being met in that situation for that type of PPE. In terms of infection control procedures, we used a very similar response key where we asked people about different types of infection control procedures. I'm going to show you the types on the next slide. We asked about if it was appropriate and adequately implemented, if it was appropriate but inadequately implemented, if it was the inappropriate type of infection control procedure, if it was lacking in the workplace. Again, when people told us that they needed that type of infection control because it was either lacking, inappropriate, appropriate but inadequately implemented, or adequately implemented, we said it was needed. And when they told us it was appropriate and adequately implemented, we said that need was being met. In terms of the infection control procedure, in the healthcare sample, we asked about 10 different types of infection control procedures. These are everything from organisational level procedures, such as screening incoming patients or cohorting patients which had symptoms, to more engineering type solutions, such as ventilation systems, airborne infection isolation rooms. Similarly, in the healthcare sample, we asked about 14 different types of infection control procedures. And again, these range from organisational type of procedures such as the isolation of people, different reporting procedures, to engineering type of controls such as increased ventilation, the installation of physical barriers. So a wide variety. And then for each of these different types, we looked at the total number of needs that a person had and the proportion of those needs were being met. And then we grouped them into those 4 groups that I described above. In terms of the results, so this describes the distribution of the anxiety scores. The healthcare sample here is in the blue bars and the non-healthcare sample here is in the gold bars. So you can see that the anxiety symptoms are higher in the healthcare sample, which is what you'd expect based on the fact that these are really people which are at the front line, than the non-healthcare sample, which has a mixture of people who are on site and those that are working remotely. 55% of the healthcare sample screened had scores of 3 and higher, which is the screening point for anxiety disorder, compared to 42% of the non-healthcare sample. And 16% of the healthcare sample and 10% of the non-healthcare sample were at the maximum possible score for the scale. Looking at the depression scores, the depression was slightly lower in terms of an anxiety compared to anxiety. Again, healthcare here is in the blue bars, with non-healthcare in the gold bars. 42% of the healthcare sample had scores of 3 or higher for depression, and 35% of the non-healthcare sample had scores of 3 or higher, which is the screening point for depressive disorders. In terms of the perceived adequacy of personal protective equipment, again among healthcare workers, and this is now restricted to site-based workers in our non-healthcare sample. So in terms of the PPE, we asked it of everyone in the survey, but it was only really relevant for those who are working on site. So you can see again, the healthcare sample is here in blue with the non-healthcare sample in gold. In terms of having 100% of the PPE needs being met, 18% of the healthcare sample had 100% of their PPE needs met compared to 37% of the non-healthcare sample, but the distributions are quite different, where we have a higher proportion of healthcare workers having 50 to 99% and 1 to 49% of their PPE needs met. So at the other end of the scale, 16% of our non-healthcare sample have none of their PPE needs met, and 8% of the healthcare workers have none of their personal protective equipment needs being met. For infection control procedures, again, we see very different distributions among the healthcare and non-healthcare samples. About 20% in both samples had 100% of the infection control procedures being met. A higher proportion of healthcare workers had 50 to 99% of their infection control procedures being met. And again, we have 22% of the non-healthcare sample and 14% of the healthcare sample, which had 0% of the infection control procedures of their needs being met in their current work. So one of the things we wanted to do was look at the adjusted proportions of both anxiety symptoms and depressive symptoms. So we wanted to adjust for a variety of different other factors that might be related both to personal protective equipment needs and infection control procedure needs, and also could be related to our different mental health outcomes. And we had a large range of different covariates that we could adjust these models for. So we've got things like age, gender, visible minority status, where people were living. For the healthcare workers, we asked about the type of healthcare facility. So if it was a hospital, a retirement home, a long-term care home, if it was in the community. We asked about workplace size, if people were supervisors or managers in the non-healthcare worker sample. We asked about different COVID-related exposures, so that if people had contact with someone who had COVID, they'd experienced COVID symptoms, they'd received training in relation to COVID, and also we adjusted for the date of the survey. One of the things we did in terms of the estimates that I'm going to be presenting in the next few slides, so these are adjusted proportions. We've accounted for the survey design. For those of you who like to get underneath the hood in terms of the statistics, we've used a jackknife procedure to adjust for the variance estimates. I'm not presenting the variance estimates, but I can talk about statistical significance if you like, and I'm happy to take questions at the end. But the main thing is that the estimates I'm now about to present are adjusted, so they're adjusted for all these other covariates that you can see on this slide, so that we can really isolate what is the relationship between the adequacy of PPE provisions and infection control procedures and anxiety and depression among these workers. So these are the adjusted proportions of anxiety scores of 3 and higher in our healthcare worker sample. So on the left-hand side is around the personal protective equipment needs, and on the right-hand side is around the infection control procedure needs. And you can see that there's a very strong graded relationship here, where the worse off you are, the higher the symptoms of anxiety are. So it goes from 43%, where workers have 100% of their PPE needs met, to 50%, where it's 50 to 99% of their needs being met, to 56%, where it's 1 to 49% of the needs being met, to 61%, where none of the needs are being met. So we see this very clear graded relationship between the adequacy of PPE provision and anxiety symptoms. Similarly, for infection control procedures, we see a similar graded relationship, going from 44%, where workers have 100% of their needs being met, to 61%, where workers have 0%. And again, a graded relationship, so that for each level of, as the infection control procedures are less adequate, the anxiety symptoms are increasing in terms of the sample in this healthcare worker sample. We see, while there are lower prevalences, we see a similar graded relationship when we look at symptoms of depression. So again, going from 33% with 100% of the needs being met to 45% with 0% of the needs being met. Similarly, for infection control, we see go from 30% to 49%. No clear differences between the 50 to 99% and 100%, or the 1 to 49% and 0%. But again, a clear graded relationship where it's increasing for every difference in terms of infection control procedures. In terms of the non-healthcare worker sample, so to start with, we looked at differences in anxiety and depression among people who are working remotely to those who are site-based workers and those who are no longer employed. And we saw that those who are working remotely had the lowest symptoms of anxiety and lower symptoms of depression compared to those who were on site and those who are no longer employed. But then we started looking for we're looking at the relationship between infection control, procedure adequacy, and PPE adequacy among those who are site-based workers. So this is looking at symptoms of anxiety among workers, again comparing all workers in our sample, so going from those who are working remotely to those who are at work with 100% of their PPE needs being met, all the way to those who are at work with none of their needs being met, and those who are not working. And you can see here that those who are at work with 100% of their needs being met have similar levels of anxiety to those working remotely, and the highest levels of anxiety among those who are at work, site-based workers, with none of their PPE needs being met. Similarly, for infection control procedures, we see an even stronger relationship with those who are at work at the lowest levels of anxiety, lower, about 5 percentage points lower than those who are working remotely. And again, the highest levels of anxiety among those who are at work with none of their PPE needs being met. The relationships with depression are very, very similar as they were in the non-healthcare worker sample, but in the interest of time, I'm not going to present those today. So just briefly around the strengths and limitations. Obviously, there's issues around the representativeness of convenience-based samples. However, I think this is balanced by the need to assess what are the experiences of workers in a very rapidly changing environment. And so, there wasn't really the luxury of being able to develop a sampling frame and go through those procedures where the situation was changing quite dramatically. And thanks to, the flexibility of OCAL and the flexibility of the different labour organisations, we were able to get this survey into the field and gather a large number of responses in a very short period of time. Given the dynamic nature of COVID, the experiences obviously only represent the points in time when we've done the surveys, so we don't know how they would extend to the current experiences of workers. I will add that both surveys are still open, and I know that OCAL has been talking about relaunching some of the surveys so that we can better understand, have the experiences of workers improved during this second wave of the pandemic. The exposure is only based on perceptions of need. However, we did examine the relationship between the number of needs and the outcomes, and it didn't really change the results. So this is not just about people who think that they need more in terms of PPE and infection control procedures have high levels of anxiety. It's actually whether those needs are being met, which is the important driver of the relationships that I've presented today. And also, perceptions are important, so perceptions should be addressed. If people have a perceived need and that need, and the science says that need is not required, then that's fine. But in the absence of science to say that the need shouldn't be met, well, we should follow a precautionary principle. We should provide workers with all the protections they need in the absence of evidence that those protections are not required, or workers should be provided with those protections following a precautionary principle, which is one of the main findings to come out of the SARS Commission a few years back. So in terms of key messages, just to finish up, so the purpose of providing and implementing personal protective equipment and infection control procedures is about protecting workers from COVID infection. And that is the purpose of doing these things. However, not adequately providing personal protective equipment and not adequately implementing infection control procedures not only increases the risk of COVID infection, but is also associated with mental health symptoms. And this is an important finding which we need to better monitor throughout the pandemic. So strengthening and monitoring both employer-based infection control procedures will be important for all workers in all workplaces. So we've seen a strong graded relationship both among healthcare workers and among workers who are not in healthcare but are working on site at their employers. And so we need to strengthen and monitor these systems in all workplaces. As well as that, we need to monitor the mental health symptoms of workers. And it's important to note that working at the workplace where all your needs are being met is associated with lower symptoms of anxiety than working at home. And so in terms of our sample of non-healthcare workers, the workers who were doing best in terms of anxiety symptoms were those that were still able to go to the workplace but had all their infection control procedures being met. And so, of course, the ongoing monitoring of mental health of workers and their infection control procedures and the provision of PPE is warranted over time. And so we should be doing more to really assess how well these needs are being met and what the symptoms of anxiety are among workers. I just want to quickly, just a quick note before I close, just around workplace communication of COVID cases. So in both samples, we asked people if they could tell us how many workers had been infected in COVID, suspected, presumed, or confirmed in their workplace. And we noticed that quite a large number of workers in the healthcare sample, which are the blue bars here, and the non-healthcare sample, which are the gold bars, said they didn't know. They didn't know how many workers, so they're at the workplace, but they didn't know how many other workers had been infected with COVID. And in our models, we could look at the relationship between this factor and anxiety symptoms. And here is, again, the adjusted proportions of anxiety scores from our sample across these different categories. And you can see here, not knowing is about the same as knowing that there's a lot of workers that have COVID infections. So similar results, 55% of healthcare workers who didn't know how many other workers had COVID, had anxiety symptoms, which is similar to the number of healthcare workers who said they had 20 or more employees had COVID, had been diagnosed with COVID. And you can see a much stronger graded relationship among the on-site non-healthcare workers, where again 53% of those who said they didn't know had symptoms of anxiety. So I do think there's an important message here around, can we effectively communicate to those workers who are on site about the number of people who have COVID cases? And I understand there are issues around privacy, but I do want to give a demonstration here of an employer in Ontario who's actually doing a pretty good job of providing the public and their workers with information on the number of workers who have COVID infections, and that's the TTC. So you can go to the TTC website, and they update it quite regularly about how many employees at the TTC have COVID. So at the moment, as of November 4, it was 141 employees, and they give descriptions of where those employees work. And I think this is not only important for the public, but it's also important for other TTC employees, that they can better understand what are the rates or the numbers of workers among the TTC who have COVID. And so here's an example of how it could be done. And as I said, one of the interesting things to come out of the surveys we did was around how not knowing is actually as bad as knowing that there's a lot. And so by providing some information, I think it's a step in the right direction. So for more information, we have the studies today have both been accepted for publication. The one on healthcare workers has been published. Sarah, if you could just pop in these links into the chat box, that would be great. We did an article for the conversation, which is a lay summary of the healthcare finding. The article on non-healthcare workers is coming out. It's just been accepted in the Annals of Work Exposures and Health and should be published in the next 2 weeks. For those who want to keep up to date on the evidence practices about this study and other studies from the Institute for Work and Health, you can follow us on Twitter. You can subscribe to our event notifications, connect to LinkedIn, or become subscribed to our YouTube channel. So that's it for me today. For those who would like to contact me, my email address is here, and also the links to subscribe and also to attend other sessions of the Speaker Series presentations. Thanks very much.
Thank you, Peter. That was really interesting. I know we've going to open everything up now to questions. Sarah, I don't know if we have any questions at the outset. If you need some time, I can ask a question.
There are some comments. People are saying thank you and they really enjoyed the presentation. No questions yet.
All right, maybe I'll start while people are thinking and typing away. I know, Peter, you said that you would like to continue with the study and keep collecting data. And these particular data came sort of earlier in the first wave when there was a lot of anxiety. And I think your study really highlights the anxiety about the future and the not knowing. And that was really interesting with the not knowing was as anxiety provoking sometimes as the knowing when it was really bad. Do you have any sense at all from speaking to some of your stakeholders and others about whether there have been changes in terms of people enacting new infection control procedures and anxiety perhaps changing, more PPE being available? Do you have a sense that the second wave is creating new issues or resolving some of the previous issues?
Yeah, so I mean, I think we need to collect the information to better understand how the changes are progressing. I mean, we've heard anecdotally that the provision of PPE, the initial shortages, have been overcome in a lot of the different healthcare settings. I don't know the extent to which those issues are being addressed in the on-site settings, and I also think there's probably a lot of variation. So you know, we saw in the initial healthcare settings, even just around the outbreaks in terms of long-term care homes, that there's a lot of variation around the provision of PPE and infection control procedures across work sites which are otherwise similar. And I imagine, you know, again, we hear in the media about differences in terms of the different procedures that have been put in place at restaurants or at banquet halls. I do think there's an important need for the ongoing monitoring, but I also think we also want to better understand what are the stories from workplaces about what have they done that's been effective. You know, what have they done that's not been effective? I think, you know, this, you know, when you have a one in a century pandemic, obviously we're learning stuff that we've never learned before. And so I think it is important to have a more open dialogue where we can share some of this information about what works, what doesn't work, what are feasible solutions that are effective. You know, but again, this does come back to better understanding how many cases are we getting at the worksite, which is still one of the big information gaps, is we actually don't know how many cases of COVID that occur in Ontario today are work-related. And so that's another gap, which I think will help, you know, joining all these dots so we can better understand how to protect workers as we reopen the economy.
Okay, thank you. Sarah, do we have any questions?
Yes, there's a question about PPE. The person would like to know what types were included in the survey. For example, plexiglass in non-medical settings.
Yeah, so
you did list some.
Sorry. So plexiglass is an infection control procedure. I mean, I guess, you know, personal protective equipment is usually something worn on the worker. So the types of PPE that we assessed were things like masks, so N95 masks, surgical masks, face shields, gloves, access to soap and water, hand sanitizer, respirators. So these are things which are usually worn on the worker. I mean, if you think about it from a hierarchy of control perspective, PPE is the least effective, or you'd want to at least do it in conjunction with adequate infection control procedures. When it came to infection control procedures, we focused both on organisational level procedures, such as staggered schedules in non-healthcare settings, you know, different cohorts, isolating patients, screening procedures, but also engineering controls, such as erection of plexiglass, ventilation, increased ventilation. So we had airborne infection control rooms in the healthcare setting, increased ventilation in general in the non-healthcare setting. So we did assess a wide variety of different PPE and infection control procedure needs. I guess that answers the question, but just to point out that really from a prevention perspective, you want to be doing them in concert, and you'd expect that the engineering and organisational controls would be more effective than just giving everyone a mask and not doing anything at the organisational level.
And there's thanks, Peter. Another question about anxiety levels. Why do you think there was less anxiety experienced by workers who are working on site with all the safety protocols in place than those that were working from home?
Well, I think, you know, similar to the heterogeneity I described before around site-based workers, there is probably a lot of heterogeneity in the people who are working from home. One of the things, you know, at the speed that this survey was put together, the focus was quite heavily on what are the experiences of workers who are still on site. I think if we were to be able to tease apart people who are working remotely from those who are, you know, who have an office which has been set up, those that don't have kids nagging them, not nagging them, asking questions, I think is what I'm meant to say all the time. You know, those we probably see a bit of variation in the people who are working at home group as well. But I do think, you know, it comes back to the point, you know, we have I guess a conceptual framework of vulnerability that we use at the Institute, which is around the people will always feel better when they're exposed to hazards if they're protected from those hazards. So if they have agency over protections, those are the workers that feel better. And so I imagine for people who are working at home, again, there are hazards involved in working from home. If workers can be adequately protected from those hazards, we probably see the variation among workers who are working from home as well.
Great. We have a lot more questions, so just keep that in mind, Peter, when you're answering. Thank you.
Okay.
Can you speak about the group of people who do not have any anxiety or depression? Why do they not feel anxiety or depression?
Well, it's a pretty, I guess it's a pretty small group in terms of the ones who actually had a score of 0 in terms of the anxiety and depression. I think we'd need to better understand it in terms of, I think everyone's feeling a certain level of anxiety at the moment in terms of the screening instruments. The levels we've seen are quite high. I don't know. I mean, you know, maybe they're just, as I said, they could just be, excuse me, either well protected and, you know, I feel like they're in a pretty good situation. Maybe they're, you know, sort of have a different a frame that they're using in terms of their assessment of their current situation. So I don't know. I mean, it's an interesting question, one that we haven't looked at yet, but we could.
Thanks. And here's a question somewhat related, but interesting. Do you feel it's important to say that to note the exact location of cases, or is it okay to just have the total number? Thinking of the TTC example with locations seems a bit intrusive, the person says, but interesting.
I think, yeah, so certainly there's a need to adequately balance an employee's right for privacy with the knowledge that it would give other workers in the workplace in terms of, you know, in terms of being able to assess their risk in terms of where they were in terms of the workplace. I think, I mean, obviously the TGC, I think, is a good example. There's probably other examples we can work from as well. Clearly, it's going to be a little bit different in a small organisation compared to a large organisation. But I do think, you know, if we think about a worker's right to be protected, when it comes to a disease like COVID, which is transmitted not off surfaces, but mainly through people you come into contact with, part of that right is about knowing, you know, are there people in my workplace which have COVID or had COVID in terms of assessing my own risk and what I need to do. And so, you know, I don't know what the right balance is, but I think the TGC is an interesting example of someone who's really been proactive when it comes to this.
Okay, great. Did your study also look at trends across healthcare sectors? For example, how the availability or the perceptions of adequacy of PPE and IPC measures impacted long-term care workers specifically? Yeah,
so we did, well, so I guess two parts. One, in our sample, we did notice that there were differences across facility types. And in particular, people in long-term care have higher rates of anxiety than workers in other settings. We have been able to work with a group at UBC, which did a survey in the British Columbia Nurses Union. And they actually managed to do a survey before, so December last year. They've done another survey just recently. We've been able to look at these 3 time points. That's work in progress at the moment. It's only based on the BC Nurses Union. And we have seen changes in anxiety symptoms in that survey, which you'd expect in relation to the start of the pandemic. We haven't got a similar survey in terms of PPE needs. And that's, again, I think a big gap at the moment is that we don't have ongoing monitoring of the adequacy of PPE and the adequacy of infection control in workplaces as we reopen the economy and as the case numbers spike. We really need to know, like, what's the adequacy like? And we don't have that information coming in at the moment. It would be labour intensive to collect, but it's probably worthwhile collecting given how strongly it's related, not just to COVID infection, but also to mental health.
Okay, and there was another question about long-term care, just whether or not you can separate out all the data from long-term care against other healthcare sectors.
Yeah, so we can, as I said, facility types in the model. It's interesting in terms of the adequacy of PPE. there wasn't that difference in the long-term care setting compared to, say, a hospital setting. The areas where it's really low is around community settings. And that makes sense, right? You think about people who work in the community, we're probably a little bit slower in terms of the adequate supply of PPE, but we did know in long-term care higher levels of anxiety. And as I said, those results are forthcoming.
And another question about the Public Health Agency of Canada, since they've changed their description of transmission to acknowledge the importance of airborne and aerosol transmission. Have you shared the results with them to inform their recommendations for PPE?
Well, so our results don't really get into the actual transmission route. I do think in terms of, I mean, the one comment I will make, which I sort of alluded to in the presentation, is that, you know, in the adequacy of evidence that a particular type of PPE is not needed, under a precautionary principle, it should be supplied. And that's, I think, one of the lessons that was learned from SARS, which has not been well remembered in terms of the current pandemic. So until we have evidence that you don't need the PPE, you supply it, because it's better to take a precautionary approach for people who are risking their lives on the front line than it is to sort of say, well, we'll supply it once we have adequate evidence that we need it. So a precautionary approach is the approach that I would recommend, and was certainly the approach that was recommended following SARS that we should always take. So until we have evidence that it's not needed, we should supply it.
In the infection control procedures, do you have a sense of anxiety related to added exposures, like to disinfectants, for example, which can lead to occupational disease aside from COVID-19?
Yeah, look, I think, again, another really interesting area in terms of the current pandemic. I know that Lynn Holness and her group is doing a lot of work just around, you know, the issues around skin and dermatitis. If you think about how much more we're all washing our hands at the moment, and that has real consequences for in terms of skins and rashes and things like that. And so I think we need to understand this in a lot more, in a lot more ways. And I know that we're doing a lot of work at the Institute, pivoting to better understand the experiences of workers in the current pandemic. But yeah, there's a lot of unknowns which are currently in play, and I think, yeah, we need to better understand them. We haven't, in terms of what are the trade-offs between different infection controls and other sources of anxiety, but I think, again, really important questions that we need to understand.
Yeah, more research for us to do. Another person had commented that you should be a member of CanCOVID, a network of researchers in Canada who are doing research in the field of COVID-19. You're nodding. And by the way, everyone, I'm not saying your names just in case you didn't want your question attributed to your name, but if you want me to, you could put it in the chat box. There's another comment and question here about communication. It seems like communication practices can be quite powerful in mitigating staff anxiety. Were there any findings around the impact of consistent messaging regarding PPE practices, IPC practices on staff mental health?
Yeah, so I think, I guess one of the things I was talking about at the end is around the perceptions. And I do think there is a need for better communication around, if people have a perception that they think the need is met, then we really do need to communicate better about, well, what's the science say? What's feasible? What can we do? And I think there really does need to be more dialogue between employees and employers around how can we make sure that people feel protected if they're in the workplace. I mean, employers have a duty to protect, and so I think as part of any organisation, any proactive employer should be trying to do surveys or ask questions of their workers about how they can better approach protecting those workers, given what we know about the spread of COVID in the workplace.
And there's another comment about the Public Health Agency of Canada. Somebody was just pointing out that they did change the definition of transmission, but they didn't recommend changes to protections for workers, though they did increase protection recommendations for others, like 3-layer face coverings. Thank you for that comment. Was there a difference between men and women in the way the needs were met? Given that your sample is really large, did you try to stratify on gender instead of adjusting on gender? This might give some insight. Sorry, they say also this might give some insight for intervention or change in order to focus on subgroups.
Yes, so we did. So in both samples, we both looked for an interaction between PPE needs and the different outcomes and infection control procedures and the different outcomes and whether they differed for men versus women. We also looked at whether they differed for older workers compared to younger workers, given that we know that the case fatality rates are higher among older workers than they are for younger workers. In each case, we didn't see any difference in terms of the exposure outcome relationship, either between men and women for older workers and younger workers. So we have provided the most stable estimate, which is among the full sample. Again, trying to understand whether the provision of PPE differs across men and women, I think is another interesting question, which we haven't examined here, although what I can say in terms of the relationships I've presented today, which are about PPE needs met and infection control procedures being met and the two mental health outcomes, they don't differ for men and women and they don't differ for older versus younger workers.
Okay, thanks. There are only 2 more questions so far. Just letting people know there's some time for a couple more. Actually, now there are 3. Were there any differences, Peter, in the knowledge of COVID cases in the workplace based on workplace size? Some of the larger organizations might have in-house contact tracing, for example.
Yeah, so I do think that's something which we could look at. And so we don't know at the moment. We haven't examined, I guess, the finding, which is something that jumped out at us in terms of the regression models, because we had adjusted for it. We could see it in the model, and it was more just an interesting little note that I thought I'd pop in at the end of the presentation, because I do think it's an action that could be done at the workplace, which is tangible. So it's a lever that we could think about ways to address. I do think it's important, and one of the things we want to do is try and understand it a bit more. And so thank you for the question. It's something which we will examine, which is around workplace size, because obviously the challenges of providing information on the number of cases in a small organisation are also very different to those faced by a large organisation.
Thanks. Given that all involving COVID, exclamation mark, was a moving target, do you have any comments on whether the survey was reporting changes in protocol or measuring more of an overall perception? Great presentation, she says.
So, you know, well, so it's obviously a moving target. I mean, we did adjust the date of the survey. So we could look at whether the responses were being influenced by when the survey was done. We looked at both the date of the survey, looked at a square term in case the relationship was different. We didn't see that the date of the survey was heavily influencing the responses. I mean, if you remember back to that first graph, the surveys were conducted right in that first wave. I do think there is a real need to try and reconduct the survey or deploy the survey within the second wave. And so to better understand, you know, have things changed, have they improved, what can we learn over time? And so, so certainly the date of the survey didn't influence the results at the moment.
In response to a previous question should it matter knowing that a coworker has COVID-19, anxiety results notwithstanding, in terms of PPE and ICP practices? Should it matter? In a global pandemic, shouldn't we assume that risk is everywhere and plan accordingly? Or conversely, what would change in knowing, what would change in workplace practices by knowing?
Well, I guess, you know, I think at a time where there's a lot of unknowns, the more knowns you have are probably important. So having more information in the current pandemic is probably more useful. So knowing, you know, how many COVID cases are in, I mean, I take the point that obviously, unless you need to treat everyone as if they have COVID, I mean, that's the best way to go about the situation. But, you know, knowing that there's been effectiveness in terms of reduction in disease transmissions in your organisation, I think is probably a useful bit of information to know. In a healthcare setting, the fact that 30% of the sample didn't know, I think is concerning. You know, how do we evaluate the effectiveness of the provision of PPE and the infection control procedures that have been put in place, you know, being put in place as things are developing, if we don't actually know how many workers are getting COVID as a result? So, you know, I think there is an important part of knowing, but obviously I do agree that just because you know, I mean, we do need to balance that with, if you know that there's no one, you don't want to be too relaxed in the workplace setting, because, you know, that doesn't mean that the disease can't spread within your organization.
Thanks. So thanks everybody for these questions so far. There's just 4 more now, Peter.
Actually, Sarah,
and-
perhaps just one question, and then maybe people could get in touch with Peter by email. I'm just noticing we just have 3 minutes, and I just want to make sure everything's on time.
These look like short questions, but we'll see how this one goes. Did you investigate if the level of anxiety or depression was related to any absence from work?
So we did have questions about whether someone had symptoms of COVID, which the model was adjusted for. People with symptoms of COVID had higher levels of anxiety, but there was no difference in the relationship between the exposures and outcomes for people with and without COVID symptoms.
I have this question, it's actually a 3-part question, so it's quick. Did the data show any insights between the different locations that you surveyed? Different locations across Canada, provinces, etc. The person's wondering if COVID hotspot locations showed more anxiety than non-hotspot locations.
So we did notice that there was lower levels of anxiety and depression in BC than there were in Ontario, which I guess is in line with the case counts in those provinces at that time. We haven't dug into much more of the differences around urban and rural differences yet, but certainly from the perspective of the province, we didn't get a lot of responses from Quebec, but anxiety was higher in Ontario, which had a higher case rate at the time, and BC, which had a lower case rate.
Thanks, that was all the questions. Great questions, thank you everyone.
Okay. Thank you very much, Peter. I really appreciate this presentation, and I also would like to thank everyone who joined today. We're hoping that you'll continue to join our speaker series. Our next presentation is on November 24th, where we'll have a presentation about disclosure of episodic disabilities in the workplace. As Peter has on his last slide, please do join us and sign up for our monthly e-alerts and notifications. And again, thanks to everyone, and thank you, Peter, for all your work. We hope that, we won't need to be getting updates as we move forward to a vaccine, but look forward to hearing more of some of the sub-analyses and other work that you've been doing. Thank you very much, and thank you, everyone.
Thanks, everyone. Bye.
Bye-bye.